Hi, everyone. It's 12:30. It's John Snyder again. Welcome to Thursday's Lunch and Learn, a Newton-Wellesley Medical Group production for everyone who wants to sit in and have some lunch with us and learn a quick topic for 30 minutes. Today, I'm pleased to welcome Rick D'Angelo to Lunch and Learn, and he's going to do some epic updates, talk about some things that are coming down the pike. As you know, we are able to get CME credit for these. The code today is REFZEH. That's REFZEH. I will put that in the chat box as we do on our medical calls. And if there's any questions about getting CME, let me know. Also know that this is being recorded, as all Lunch and Learns are, and they are posted up on YouTube, and we will try to send around that link. I'd like to tease next week's Lunch and Learn with Drs. Sheila Partridge and Susanna Wishnia, updates in weight loss surgery, and we have a lot of other great topics coming your way. Just so you know, the other ones, as I told you, are posted up on YouTube. So I'm going to stop sharing and stop talking, and Rick is going to take over. Go ahead, Rick, and see if you can grab the screen.
Great. Thanks, everybody. So I have 3 topics today, and unlike when I usually do this, where I like to make it interactive and do a lot of questions, and certainly I will be open to questions, this is kind of 3 things coming up. One old news, one medium news, and one some brand new news. And so I'm feeling a little like a school teacher here, like this is coming, you need to know this. If there's time at the end, I'll try and stay open to some just open epic topics. I lost my chat box, but hopefully John will monitor the chat box and let me know if I have questions as we're coming along. So starting with the oldest topic, electronic prescribing of controlled substances, EPCS. As hopefully you all know, and if you don't know, this is new to you, but this is somewhat old news. It was going to be January 2020, all providers, prescribing providers in the state of Massachusetts were only going to be able to prescribe controlled substances through an electronic prescribing platform, either through Epic, or for those not on Epic, there's a variety of other platforms out there. That was delayed for once something non-COVID related. It was delayed until January 2021, so status quo ante prevailed for 2020. But as of January 1st, 2021, you will not be able to prescribe controlled substances, with very limited exceptions, to your patients unless you are on the electronic platform. Most of you are, and I think COVID really proved the worth of this. I don't know how providers who aren't up in this dealt with Adderall prescriptions, Percocet prescriptions, Valium prescriptions when they had to have patients come and get them or mail them and risk, 3 days in the mail. So, hopefully the bulk of you are up. This is old news. You can kind of zone out for a couple of minutes while I go through this. For those of you who are not up, we can get you going. Some of you are kind of partially up. You've done the form, but haven't implemented it on your phone, and we can do some help there. We are hearing from some providers that they don't prescribe controlled substances and they don't need this. And that's fine if you're truly prescribing 0 controlled substances. So, you may well be a dermatologist who very rarely prescribes, but twice a year you get a nervous patient who wants a Valium before taking a big mole off the back, or, something similar. You're a pulmonologist who doesn't do pain meds, but every once in a while somebody needs an MRI and you give them a Xanax for the MRI. If you are not up on EPCS, you will not be able to do that come January 1st. So, I can't say enough about that. If this is a part of your prescribing, you must get up. There is a financial incentive through the PHO that you will forfeit if you are not up by September. I put the names, both the names are here and they're in the chat box. You can always reach out to me if you can't find those names, and I can pass it on. As with all 3 of the topics I'm discussing, please pass this on to the other providers in your office. Again, this is old news, hopefully, and most of you who are on this call are already up. But if you're not up, or if you know some of the providers in your practice are not up, please pass this on. So any questions on that at all? Anything on the chat box?
No.
No. Okay, Storyboard again. So this is medium news. Hopefully you've started to hear the discussions on this. This is a new look to Epic. More data is immediately available without maneuvering through the chart, without pressing activities. Activities that were formerly on the left side of the screen and moved to the top. So right now, as of right now, you can toggle this look on and off, but come August 22nd, Sunday, August 22nd, or for many ambulatory providers, Monday morning, August 23rd, this is on and cannot be turned off. Please note this affects all users. So this call is directed mostly at providers, but this affects your front staff, your nurses, LPNs, MAs, anybody who uses Epic, their look will change. So it's worth everyone taking a look at this before. Obviously, we'll help you at any point. We're available for help August 23rd. But as you might imagine, as with any new major change, the help desk is probably going to be inundated with people who did not take a look ahead of time, and you may well struggle, to have to wait half an hour, 45 minutes to figure out how to do something. So we would strongly encourage you all to take a look right now. Storyboard, just to drill into it a little bit, it is individualized. So the storyboard you see, the story you see, depends on your specialty. The idea is what Epic is trying to do is trying to anticipate what you as an orthopedist, what you as a primary care doctor, what you as a general surgeon most need to see and don't want to futz around with 3 clicks in the chart before you find it. So we have a couple of examples here. So for an orthopedist, you can more readily see the principal problems. X-rays are much more prominently noted. For an IVF doctor, the menstrual status is up front. For an ophthalmologist, you can see the imaging procedures are right up front, and it actually gives a directed problem list of just eye and vision problems. For behavioral health, it's a little less specialized, but even there it is. And I want to, here, there's a few more here. OB, again, the OB labs, this is for inpatient. IP means inpatient. So if you're an obstetric provider, this is what you would see in the inpatient setting. See the blood pressure and the heart rate. You'd see who the OB provider is, pre-gravid BMI, the GP status, gestational age, and the blood type, the stuff that you most need to see right in front of you. And this is the slightly different, the outpatient provider where the labs are more up front. So here, let me show you a live Epic. So you can see for a primary care doc at least. There we go. So for a primary care doc, the vital signs, for example, now this guy only has one set of vital signs, but you would see if there were vital signs from the past, you would see a cascade of his most recent vital signs. You see his health maintenance issues. So what are his gaps? He needs a tetanus shot and a TSH level. So that's right up front, the problem list. Allergies. There's a phrase you may or may not remember and you may or may not be annoyed by from your training, hover to discover. That becomes really important with Storyboard because a lot of what you'll see, you hover. So right here, you see these last 10 visits. Well, if you hover over that, you can go directly to the notes. And again, this is a test patient, so it doesn't demonstrate it well. But imagine if that said encounter with cardiologist, you would click on it, and right there would be the notes from that cardiology appointment. So without having to go to chart review and encounters, you can still do that. You're going to have all that right here. As well, no results. So again, I'm in the test environment, but if there were recent labs, I would hover over that and we would see what labs were done. I would see CBC, I would click on the CBC and I would see the results from that CBC. All the stuff that was on the left is here on the top in the same order. So everything that was here is now here. But the hope is that that you will less need to go from activity to activity because things are more in your face. And if you want to, instead of going to chart review encounters, you're going to go to last 10 visits and say, oh, I want to look at this note. And you would see the notes from here. Already, another step in this pathway, we already know the orders bar is already up front. And one thing coming that got less press than Storyboard, there's going to be another plus right here that's going to be add visit diagnosis. So again, less need to go to that plan section. You can go here and say, I'm going to deal with the patient's bipolar disease, diabetes, and add those visit diagnoses right from here. So more and more, this is the kind of the direction Epic is going, where they're hoping to anticipate what you want. Right now it's specialty specific. At some point in the future, it might even be visit specific. So this isn't going to happen August 23rd, but at some point in the future, it might be, if this was a consult versus a follow-up, you might see different things in the storyboard. And again, this applies to your nurses and your front staff. So, you know, if you have some of your nurses are a little bit Epic challenged and don't deal well with change, then I would strongly encourage them to take a look right now. So it looks like no questions on that. Oh, let me show you how to toggle that on, because right now you can toggle that on and off. So yeah, let me, oh, I'm in the wrong toggle. So here, I'm moving this over to the non-storyboard. So this is the traditional view. I probably have more activities than most of you have, but you know, all of you have some set of activities. So if right now you want to see what storyboard is, you're seeing this traditional view of Epic. You go to this customize button at the bottom of your activities. You press that, and then you get this screen, and you'll press here, move tabs to the top. And now those tabs have moved from here to up here. And I'll show you how to turn that off. Again, you won't be able to turn it off come August 22nd. But for right now, if you say for today, I want to go back, the wrench is now up here because those activities that were here are here. You press the wrench and you say move tabs to the left. And you go back to the traditional view, the old view, whatever you want to call it. And again, just to make sure people understand, that toggle will go away come August 22nd. Right now you can toggle back and forth freely as much as you want, but August 22nd, no more toggling. This will be the view. This will be the Epic view. So no questions on that either.
Rick, can you customize how the storyboard board looks on the left, or
No,
that's the order that's in? Okay.
No, it's pretty similar to kind of the way, you know, people have often asked, you know, chart review, how does, you know, can I wish that, you know, medications were above problem list. That is not wrenchable at this point. So,
okay.
So that's the way it is the way it's laid out, your specialty. That may come in future iterations, but not currently.
Rick, I think this is Jeff. I think the other thing that, and I'm sorry if you mentioned this, but what I sort of found as I was playing around is under care gaps, you can actually order the things that are due, or sort of set up that order, open up the smart set by clicking on the slider to the right there. So it does, you know, at least for PCP, I think helps tee up the visit.
Yeah. Yeah, and the vital signs, I think for primary care, there are some very obvious improvements, you know, the vitals that will cascade here, the last 10 visits. So you get, you know, somebody who's seen a bunch of specialists, instead of having to go to chart review and look at encounters and, you know, weed through the phone encounters. This is going to be, all right, oh, what happened with the urologist? And again, this is a test patient, so everybody just puts orders in. But if this was an office visit with urology, I would click that and I would see the urology note, and then I could go to the cardiology note and whatever. So, you know, there's some obvious benefits, but there's obvious benefits in the other specialties too, because for orthopedics, for example, their interest level is even more coned down. So it's even hopefully easier to anticipate what they want. So plain films, for example, will be very prominently here and able to be hovered and seen. So you're the hip doc and you want to see their last set of hip films, you won't need to go to chart review, to imaging and see them, but they'll be here and just one click away, or maybe even a hover away, depending on exactly what it is. So it's one that really does reward playing around. As with any major change in Epic, you know, kind of step one, day one, you want to make sure you can do everything you need to do. That you don't lose anything. We want to make sure our upgrades don't cause you to go backwards. But in the longer run, we want people to get the benefit from this. And it does take a little bit more hunting around, using that hover to discover concept to get that benefit. Okay. All right. So then going back to the PowerPoint. So the final thing, and so this is a new topic. And this one I think is going to be some controversy. So right off the bat, I'm going to say don't shoot the messenger. And this is something that actually no one at partners, we're all the messenger of partners. This is based on federal regulation. So let's back up. Open Notes is something that we voluntarily participated in for about, I think we went live about 3 years ago on the ambulatory side. It meant that notes and the ambulatory setting were shared with patients through Patient Gateway. Providers could opt out of it on an individual note level. And actually, there's even a secret button that we didn't publicize that people can opt out of sharing their notes totally. There was no mandate to share. We strongly encouraged it. Most specialties shared most of their notes. There were some subsets of specialties that didn't share many or any of their notes. And so be it, that went on its way, and we were kind of at a status quo there. However, as of about 2 months ago, there are new federal regulations coming out. Here's the U.S. core data for interoperability. It's included in that all notes, all information must be shared with patients. And importantly, this includes a lot more information, including inpatient notes, ER notes, psychiatric notes, many things that have not been shared. And there is now a mandate to share. Providers can opt out of sharing an individual note based on a specific patient need to not share that note. So right now we have some specialists, some providers who are not sharing 90% of their notes. That will not cut the mustard. You can choose not to share with John Smith, but you will need to say, on June 29th, I didn't share with John Smith for this specific reason, that there could have been a clinical harm to the patient. And you need a good reason, and you will face very large fines if not. This is very fresh information. We still haven't heard all the compliance. We're not sure what the wording on sharing, not sharing can be. We're not sure if there's going to be a specific threshold where if you're not sharing 90 or 80 or 70% of your notes, if you're going to be audited, that's still all TBA. A big TBA is the adolescent piece. It seems that adolescent notes do need to be shared, but we may work on changing the way Gateway itself works. This does not include staff messages and phone messages currently. Staff messages it likely will never include. Those are not part of the chart. It will in 2 years include telephone messages, but it does not currently include telephone messages. Here's the list of, they tried to be as broad as possible, but you can see here the list of what is included to be shared.
Rick, there's a question about the psych notes that sometimes we can't see as primary care providers. Does this affect that at all?
No, yes, we should be able to see those notes as well.
And then there's another question about break the glass. Are those policies going to change at all with this?
Still TBA. I don't think so, but still TBA. Here, we get back to my PowerPoint here. Because again, this is very fresh, so it's coming. So what will happen? I mean, some of this doesn't affect us. There are actually some entities, Martha's Vineyard or a few others that are up on Open Notes. They'll be going up imminently. The global provider opt-out that, again, we've never publicized it, and I think only a couple of dozen people in Newton-Wellesley found it. That's going to be turned off in a couple of months. And then here are the big changes, the Psych Notes. Right now, there are some departments that we kind of define as close to psych, social work, and those are turned off from sharing the notes. Those are going to be turned back on. We're going to have to do some good education with both the inpatient docs and the ER docs, because those notes will be shared. As I noted, adolescent notes, still TBA how that's going to work. It seems they do need to be shared, but we may make some changes to Patient Gateway to make it a little bit harder for parents to get in without the adolescent permission. Again, you will be allowed to opt out of individual note sharing, but you can't opt out of all notes, as this is considered information blocking. And I think that's worth talking about. It's just words, it's just phraseology, but the concept is you are not sharing your note with the patient. The concept in these regulations is this is the patient's information. All of this is the patient's information. If you do not give the patient immediate access to it, you are blocking their access to their own information. So we're going to get rid of that concept of sharing our notes. They're not our notes, it's the patient's information, and are we blocking or not blocking it? As well, some things not on the slides. It seems that most of the embargoes for labs and radiology will go away. So all labs and all radiology likely will be immediately available to patients come November 2nd. So I know that's kind of a big bomb. Let's see how much. No, they wouldn't be shared if they're incomplete, only after they're signed. So that's an easy one. Staff messages wouldn't be, that probably never would be included because staff messages quite explicitly are not part of the patient's chart. So any questions, anything anybody wants to discuss? You can unmute yourself. No, it will not be retroactive. As with initial, whatever day partner, Mass General Brigham makes this change, and it will be by November 2nd at the latest, but likely end of October. So, make up a date as of October 21, it will be all notes going forward. It will not be retroactive. And if on October 20th, you chose not to share a note, that will not be then shared on October 21st. And what did Julia just ask?
Julie wants to know if you can share the slides or get them out. The palliative care providers are certainly concerned about sharing notes.
Sure. So what I would expect, and again, this is pretty hot news, and it's still a lot TBA. Certainly, I would expect different specialties to have different rates of information sharing. So palliative care, hospice, substance abuse clinics likely will have a much higher rate of non-sharing, and that will make sense. The key point will be, can you justify a specific reason for that specific patient? So, global opt-outs won't work, not sharing any of your notes won't work, but, say have something like, we'll be giving the patient this information over the next 3 visits because they're not ready to hear it, or some kind of wording like that, certainly will be fine. I'm not sure if there's going to be some specific wording that we'll recommend. If so, we can certainly make smart phrases for that. So more to come on that. That it? I expected that to create a bigger.
A couple more just came in, Rick. So what about an error note? There's prep notes in the future. Can an error visit be, will that be shared?
If it's errored, it should be removed. So, that is not part of the medical record. So, the easy part of it would be if right now they could get that information with a medical release, then it will be available. Yes, providers will be able to see labs and images at the exact same time. I agree with Jeff. Yes, primary care has actually had among the highest rates of sharing. I think in internal medicine and family medicine, the vast, well above 95% of notes are shared, and with minimal to no problem. Occasionally you hear back from a patient. Very occasionally, you said left and I meant right, and that's information you should have. The chart should be right, and if the patient is correcting true errors, it's annoying, but how can you really complain about that? Importantly, problem list, med list, allergies, that's already visible to the patient. So people often say, putting morbid obesity on the problem list. That has been status quo ante since Epic went live. And actually, even going back to LMR, the problem list was visible. So if the patient's problem list said morbid obesity, they have been able to see that for, I believe, a decade. It's just, the note is different.
There's a question that I think you missed in the chat box was, will patients get to see our reasons why we don't share a particular note with them?
No, if it's not shared, it's not shared. I'm going to go back to some TBA. My assumption would be if you don't share a note, it would be embedded in that note why you're not sharing it. So you know, I would assume there'll either be a smart phrase or recommended language, where at the note you'll say, this note not shared with patient for the following reasons. And so it's within the note that's not shared. Now the patient, if the patient has habituated to seeing all their notes and then suddenly they don't see it, they may ask you, why couldn't I see my note from yesterday? You know, that's something that they can ask. And remember, they would still have the right to request it through a, you know, an old-fashioned medical record request. But the point of this of these regulations are patients should not have to jump through hoops, sign a form, submit the form, wait for medical records, all that in 2020 and 2021. If this information could be available to the patient immediately, it should be, and why should they need to jump through a hoop to get to it?
Does the patient see that a note's actually hidden, or it just is nothing there? Do you know?
There's just nothing there. They would see the visit, though. I mean, you know, so, you know, it kind of depends. If it's a patient with a lot of issues and they never see notes, they may not notice. But, you know, if they, you know, they're seeing you all the time, they're going to see note, note, note. They're going to see the visit. In patient gateway, they see visit, and there's going to be no note there. So it will be relatively obvious that there's nothing there. That being said, it's I didn't put up the stats. A relatively small percent of notes are read. Somewhere around 7 to 10% of notes are read. So the pretty overwhelming percentage of notes are not read. Although interestingly, that does vary considerably from specialty to specialty. Thoracic surgery, I was noting, 100% of the notes are read from thoracic surgery. I think like reproductive endo or IVF, I forget which way they worded it, it had like a very high rate, 70 or 80%. So, you know, patients may not bother to read their back pain note, but, you know, a new oncology note, they may well want to see exactly what was in there, and did they get all did the doctor put down all the information correctly?
Okay, well, we're coming up on the hour. Any last questions while we have the Epic Guru with us for our 30-minute chat? Just want to remind people I put the code for CME in the chat box, REFZEH. I want also people to remember that you only have 24 hours to claim that CME credit from when the lecture happens. It will be up on YouTube as well for your colleagues, or if you want to watch this again. And lastly, I just want to tease again, next week is our updates on our weight loss surgery program here at Newton-Wellesley Hospital. So if there are no further comments, Rick, any final words?
No. If anybody has any kind of, you know, I'll stay on for the last 3 minutes. If anybody has any quickie epic questions, I'm happy to answer. As I always am, you know, I'm always available. I think some of the CBAs are on the call, so they're always available. And again, don't forget to mention Storyboard to your staff, because you know, if your staff is having problems, that could bring your office to a halt just as readily as if the providers aren't getting it.
Rick, give me the screen back again so I can show the code. People are asking for the code.
Yep.
Okay, there it is.
Okay, stay well, everybody. Have a good half.
See everyone next Thursday. Have a nice weekend. Bye.
Any questions, let me know.